Dyspepsia is a chronic functional disorder of gastrointestinal that causes dyspeptic symptoms in the absence of organic disease. Characterized by four main symptoms, the postprandial fullness, onset sensations, epigastric pain, or epigastric pain, without evidence of structural disease, including an upper endoscopy that is likely to express symptoms. This is the role for classification. So the patient should preserve criteria for TDS or EPS. The primary distress syndrome or the epigastric pain. According to the role for classifications, the sensitivity about 67% and specificity is about 38% to diagnose functional dyspepsia. About the pathophysiology, it is multifactorial. There is no one factor that we can detect that can cause the functional dyspepsia. The previous time we focused on the gases centric view, classically focused on the sensory and motor dysfunction of the stomach, the delayed gastric emptying, the impaired gastric accommodation. But recently, there's emerging data about the duodenal involvement in the pathophysiology of functional dyspepsia, the duodenal inflammation, the duodenal mucosal barrier dysfunction, triggers, luminal triggers in the duodenal and microbiota dysbiosis. So the brain gut axis is bidirectional pathway for the brain to gut and gut to brain. In which stress, anxiety, and depression can increase the gut permeability and activate the immune system, which disrupts the normal gut functions. And also, the overactive visceral signaling from the gut to the brain, the duodenal brain inflammation and barrier defects will send excessive and abnormal sensory signals to the brain. This will alter brain processing and the perception of pain and discomfort. Some study using imaging shows the hyperactivity in several areas, especially in the insula and the anterior cingulate gyrus and the anthalamus, which is critical for the visceral sensations. We can see that the red colors indicate the brain regions in where the functional dyspepsia patients have greater activity than healthy controls. And the green color represent the brain regions in which the functional dyspepsia patient have less activity. So the increased activity in this area involved in the nociceptive inflammation and associated with the pain related to the response. Anxiety and depression also can induce hypermetabolism in several regions in the brain, which involve in the processing of visceral afferent information and visceral perception, the insula and also the anterior cingulate cortex. We can see from this pictures that the upper one shows us that there's hyperglycemetabolism in functional dyspepsia patients compared to healthy controls. And the lower picture shows us that even in patients with anxiety, depression, with psychological disorder without dyspeptic syndrome, there is still some area that is hypermetabolism. So psychological morbidity may cause an increase in physiological sensory signals leading to abdominal symptoms. This significant psychological as a stressor in the end will activate the IP axis and triggers the CRH release. The peripheral of this CRH will travel through the intestinal lining and bind to its receptor, which is on the surface of the mast cells. The mast cell in turn will release the inflammatory mediators, will damage the tight tissue. So there is studies that shows us that there is a significant increase, especially in both eosinophils and mast cells found in the duodenal inflammation of functional dyspepsia. These eosinophils will degranulate and release cytotoxic substance which cause neural dysfunctions and activate the mast cells. And the mast cells then will release inflammatory agents including histamine, which induce eosinophils to migrate into the mucosal. This will in turn cause the impaired duodenal barrier, which lead to increased intestinal permeability and triggering low-grade inflammation and symptoms. The impaired duodenal barrier involves dysfunction of cell-to-cell adhesion structure, particularly the tight junction we can see here and the adherent junctions. And there are a lot of studies in functional dyspepsia in vivo and in vivo shows us suggests that there's higher duodenal permeability and decreased mucosal impedance and dysfunctional peripheral release pathway, and also dilated intercellular spaces. It creates a vicious cycle in which the immune system will release mediators that disrupt the tight junction and increase the permeability. The increased permeability will allow more antigens to enter the mucosa and then further agitates the immune cells and amplifies the inflammatory response. That will close the loop. So what happens? So when the activated immune cells release the pro-nociceptive substance, the pain-promoting substance, including the histamine and serotonin, they will activate and sensitize the sensory nerve endings and lowering the pain threshold, results in visual hypersensitivity. They will enhance perception of pain to normal stimuli such as acid or distensions. And also studies report the increase in expression of pain receptor like TRPV1 and TRPV2 in gastric biopsy. Also, the role of enteric glial cells are involved in the modulation of this neural function. In a study where they perform an acid infusion test, the proportions of subjects in patient with functional dyspepsia compared to those with multi-pharyngitis is whether it's the acid infusion or the water loading can significantly increase higher proportion of subjects. So they scream louder. And the fact that even the water loads can trigger this symptom, the pain, the bloating, the fullness, probably shows us that it's not only involved the mechanoreceptor but also the chemical receptor. And about the symptom, the impaired accommodation. So when we eat, the proximal stomach will relax and to accommodate the meal that we take without increasing our pressure in the stomach. So that's what we call accommodations. But in patient with functional dyspepsia, there's a significant difference of reflex, in which in 40% of functional dyspepsia patients have impaired gastric accommodations. They have reduced food accommodation in the proximal stomach. You can see this is time after meal, the accommodation volume using biostat. There's an increase in antral area because the fundus area is too tight and food retention in the entrance. And early satiety and fullness was significantly associated with impaired accommodation and functional dyspepsia. And also about the delayed gastric emptying, it was found in 20 to 30% of functional dyspepsia patients, but only postprandial fullness show little association with the delayed gastric emptying. Other key like pain or bloating have no independent associations. And impaired quality of life in functional dyspepsia was not explained only by delayed gastric emptying. I'll show you the vagal system that has altered signaling in patient with functional dyspepsia because of the increased epithelial permeability, altered gut hormone, and altered microbiome profile that we'll talk about later, and increased inflammation will change the signal vagal afferents, and also the enhanced processing in the brain will give back the afferents signal to the vagal afferent and will cause the impaired gastric accommodation and also impaired gastric emptying. About what kind of triggers that presents in the luminal duodenum that can activate the low-grade inflammations besides all those factors that we've talked about. So in post-infectious functional dyspepsia, so in a patient which has experienced an episode of gastroenteritis, they were more likely to develop functional dyspepsia within months after the initial infections. For Helicobacter pylori infection is still controversial. And about microbiota dysbiosis, there's a tendency that there's an increased streptococcus and decreased anaerobic bacteria, which will trigger the duodenal pathology in consultation with functional dyspepsia. It will cause damage to the mucosal barrier and also low-grade inflammation in these patients. So they will, this dysbiosis will impact neural signaling and will have gastric feedback in patient, leading to dysmotility and physical sensitivity. And also because in patient with functional dyspepsia, there's meal-induced symptoms, especially in PDS. Probably the food antigen, some of the food antigen can chronically trigger this inflammations. Some studies shows that wheat protein and also FODMAP diet have tendency towards symptoms improvement if we put the patients in low FODMAP diet or gluten-free diet. So this is probably the connection between the postprandial symptom onset with the duodenal immune activation because of the food antigen and also the symptom improvement with the absence or and the inclusion, the exclusion of diet from the patients. Okay, dan kami rasakan seluruh microbiota So in summary, any variety of trigger can be found inside the gastrointestinal system, the post-infectious bacteria, psychological stress also, and food antigens and other luminal factors such as gastric acid and bile will cause low-grade immune activation marked by infiltration of immune cells and duodenal barrier defect or we call it leaky gut. And it will generate symptoms, visceral hypersensitivity, impaired gastric accumulation, and delayed eating. As a conclusion, functional dyspepsia is a complex disorder of the GI defined by symptoms rather than structural or metabolic abnormalities. The pathophysiology is multifactorial, and an understanding of this underlying mechanism is essential for targeted therapy. Thank you.